In progress.
Meta zirto magat ka 7 man. Roto maga 7. I'm just learning things here. How must I make it? And I want to. Yeah, Koala. Yeah, Koala. Unmute yourself. Let's talk to the two people who are here. Unmute yourself. Let's talk. I want to test this thing. Ya kwagala. Ngaka kgomo. Makoti.
Ke a go kwa wa nkwa nna ke a go kwa.
Go Dr. Kgomo. Microphone by. Is microphone working? Can you hear me?
Yeah, I can hear you.
Unmute. Unmute yourself.
Yeah, okay. I can hear you.
Unmute. Unmute yourself. You have muted.
I can mute. I can mute. I'm not muted.
How can I unmute you? I don't know how to unmute you. You must unmute yourself. I'm allowing you to unmute yourself.
No, I am unmuted.
I can't hear you. So your microphone is muted. Go to your microphone and press it.
No, I'm unmuted.
Majaji, unmute yourself. I want to test with you and Majaji, but you, okay, yeah, now Dr. Homo can talk. You are unmuted now.
Yeah, I keep on muted.
That
doesn't allow you to unmute.
Real take definition.
No, it's nice to see you. I'll join you at 7. I was just testing my phone.
Let's start afresh.
I was just testing my phone.
You have muted now.
Yeah, okay, fine.
Let me ask my wife to connect so that I can test Kayana. Because if I don't test it now, it's going to be a problem because I can hear you. So I don't know whether you can hear me. Put it on the chat and see if you can hear me.
Okay. This one.
Go connect a Zoom to test again. Connect that thing. Connect it. Oh my God. Which I come lose.
Good day, some brothers and sisters. It's so nice to see you again. But right now, I'd like to dedicate this few little words to you. That I've been gone for such a long time, but today, that I'm back one more time. And now, I have a little pretty little young girl with me here, ladies and gentlemen. And I'd like to dedicate this few little words to you. That I've been gone, and she's been gone, but now she's back one more time. And right now, I'd like to say, you
Ngochechata kwantelele cigarette. Другая. Okay.
thing about you wanting to be a scientist before you went to do medicine? What was? Yeah.
Which rule to use?
Yeah.
That's all there is to it.
Yeah.
Still like that even today.
Yeah.
Remember the rules which rule are you to use, and that's that.
And yeah, it is a subject that most people they are very careful.
See, it's not belong to a union at all.
Yeah.
It's a calling. I still believe it's a calling, and I was happy to be a doctor.
Yes.
But I wanted my family to do well.
Yes.
That's a second thing. I loved being a doctor. I wanted my family to do well. So when I did internship and I managed to go home, and my father asked me when I was an intern, what you are doing next year? I said, I'm going to work in Attrickville. I'd already organized a place to stay and the rooms to practice, and I was going to work there.
No, just there, Prof. So you're telling me that after you qualified and you did your internship, when you did your housemanship,
I was doing internship.
Yeah, when you were doing internship, you were actually planning
to be a GP.
To be a GP.
Yes, for 5 years.
And you didn't just think about that. There were plans in place.
That's right.
You had identified the place being Attrickville.
Yes, right.
And you had already got, premises offered to you by the person who was the leader of the township at the time.
That's right.
And then what happened, Prof?
Then the night before I went back to Durban, we had dinner with my father, with the family, whole family. Then we talked about other things, and always before we went to sleep at night, one of us would pray and go to sleep. And before that, he asked me, what are you doing next year?
Yeah.
That would mean in 1963, what time I'd be next. I said, I'll be working, practicing in Attrickville, Pretoria. And he said, is there a medical school for black people in Attrickville? I said, no. You see?
Yeah.
Then the prayer time came. It was the longest I've ever had him give. But the core of it was praying for me, praying for God to correct me because I was satanic. All I think of life is money. And I don't think of things of value of the world and so on. When he finished there,
that was a heavy prayer.
Yes, when he finished there, I saw myself as a heathen, as a person who just loves money.
Yeah.
So when
you had a plan.
Yes.
That you are just going to practice in private practice for 5 years, just to get some money, invest some money, then go and specialize. But he didn't see that.
No,
he wanted you to go straight to to study further.
Because investment is making money, and he didn't think it should be the main thing in his son's mind to make money. He didn't think that way. Anyway, what he did is that when I went back, and this was the second part of 1962, it was still in July. The very first working day, I went to the Department of Obstetrics and Gynecology, and I knocked at the door of the late Professor Derek Crichton, and he says, what can I do for you, with his blue eyes, almost threatening? I said, sir, I want a registrar job.
You want to train
as an obstetrician and gynecologist. You see, I got the highest mark in obstetrics and gynae.
Yes. That is in your final exam.
Yes, the second was surgery. I mean, we were writing 3 major subjects. You see, pediatrics was part of medicine then.
Yeah.
So the second was surgery. They were good passes, both of them.
Yeah.
But I did well. In fact, I think they should have given me a distinction in obstetrics and gynae, but they didn't.
And so you went to this guy's office. You say, I want to specialize in ONG, and I'm looking for a registrar post.
That's right. Then he said, wait, right at the door half open. He went to open a cupboard, and he looked at the results. He says, oh, you're a bright boy. You got a job. I've given you a job. So he wrote the name
Easy
down.
like that.
Yeah, easy like that. So come 63, I started working in ONG.
Yes.
As a senior house surgeon. Then I became a registrar. And the rest is history.
So at that time in South Africa, was there a black, and I say black in the broader sense, was there any black gynecologist, whether it's African or Indian or colored at the time?
Yeah, there was Ibrahim Sidak, but he had trained in Britain.
Okay.
He was a very known. He was just qualified when I started. Qualified in Ireland, I think he did. Ibrahim Sidak, and it's the only one I knew. But there wasn't. If you meant black, you meant African.
African.
At that time when I started, there was. So a few years later, we had Mpatele, but he also trained in Britain.
Overseas. All right. So you were taken in as a registrar. Was it 4 years training?
No, it's long, man. 5 years is minimum.
Yeah.
And the first year you are supposed to do it outside your specialty.
Yeah.
And I didn't, and I paid later for that. And 1 year outside your specialty and 5 years. Then it's become shorter now, but it was long to do.
Well, it was almost 6 years.
It was 6 years
after you've had your 6 year undergrad plus internship.
Right. So I went straight, and in 1965 I passed the diploma in obstetrics and gynecology. That qualified me to be a junior lecturer in the university, and that's when I got appointed as a junior lecturer. That's why I taught Oldman G.G. Mbehe in his last year before he wrote.
Yeah.
It was my first class of final years I taught. It was in
I remember him at your 80th birthday party.
That's right.
He's one of the people who spoke there.
That's
with
right.
A lot of tzotsital, when he talks.
Oh, we're still great friends. We still phone each other now. G.G. Mbehe. So in 65, I did that. And when I passed there, the examiners called me after the exam. They said, why didn't you write the fellowship now? I said, sir, I haven't got enough years to write the fellowship. You see, they thought my knowledge then
was superior to somebody who just
doing diploma in obstetrics and gynecology. But it encouraged me even more because I knew, you see, those fellows came from obstetrics and gynecology in South Africa. So you get known. Yes. Then we get known. I mean, there was in Pretoria, Willie van Niekerk, there was me in Durban, there was Son and Dega in he was also in Pretoria, though he then went to Bedzaf. So the university, we used to know each other, saying, so it's the same, so I was a fellow from Durban.
Yeah.
And we're the same era. This reminds me, Son and Dega has just passed away.
Oh.
Yeah. But really passed away sometime. But Willie van Niekerk, he actually became a minister of health during the old government for a while.
Yeah.
But he was a brilliant postgraduate.
So you then, proceeded beyond your diploma in ONG and then obtained your fellowship. When did you obtain your fellowship? That is now the real, specialist qualification.
May 1967.
Yeah. So were you writing as a fellow within the South African environment or UK? Or
no, I did the South African.
South African. So you were admitted into the fellow
of the College
of ONG specialists.
Yeah, then it was, the college was one. See, now they've made it several colleges.
Yes.
It was a fellow of the College of Obstetrics and Gynecology. It was a college.
Yes.
Obstetrics and in the fellowship.
Yes.
But now it's a fellow of Fellowship of Obstetrics and Gynecology.
Okay.
They've changed them a bit.
And my understanding, Prof, you'll correct me if I'm wrong, you were the first Black African, and you were the first Black
anything fellow.
To be a fellow of ONG
Yes,
in South Africa.
Yes.
Now that's big, Prof.
Well,
what did it mean to you to achieve that feat?
Well, I really have never looked back at it, because
just
then I was ambitious.
Yes.
You see, I wanted to go up the academic ladder in obstetrics. Now I was no more, my father had killed all the ideas of making money. I thought I owed him that.
Yeah.
I owed him that. So I was looking forward to going up the ladder, which Derek Crichton gave me. I mean, soon after passing the fellowship, I became senior lecturer.
Yeah.
And when he was removed, I was a senior lecturer. And then I became deputy head of the department later.
Now, so you got your fellowship in May 1967.
Yes.
Right? And this is just about 4 months before I was born. I was born in September 1967. So when I was born, you were already a fully fledged gynecologist. All right. But you then, as a senior lecturer within the ONG department, and you now became a deputy, you didn't end there. You continued studying, Prof.
Yes.
Studying towards a doctoral degree, at the University of Natal, a PhD.
Yes.
All right. Just tell us what was the motivation there? Is it still to go up the ladder within the academic sector?
You see, what happened is that, you got to look how the ladder was. You see, you qualified, then you must get positions in the institution.
Yeah.
To be able to be influential in what you are doing. So when in 1970, I became senior specialist. In fact, before then, as soon as I got the diploma, Derek Crichton made me in charge of staff.
Yeah.
And in 1967, he made me in charge of the obstetric. And the obstetrics was the largest in the Southern Hemisphere, just the obstetrics. And he wanted me to be in charge. That gave you a lot of responsibility. It really did. But to hold this position that you are senior to, you must have letters to back it.
Yes.
So I was doing some research at the time, and as you will see later, I did some research even at that time.
Yes.
And I worked towards. I always was looking to having a PhD.
Yeah.
Anyway, in our era, you couldn't be head of a department in medical school without a PhD or without doing one about to complete.
Yeah. Well, I think at some point that thing, disappeared a little bit.
Well,
it is back now.
It better remain back because it has a lot to do with quality. You couldn't in our day, they wouldn't shortlist you. They just threw you off. If you weren't doing one and there was evidence you were doing one and already advanced, they wouldn't at all look at you.
And then in 1980, you obtained this MD or PhD.
Yes.
But before then, Prof, there are a number of guys who came after you. Professor Marivate, Dr. Pitzwe, Dr. Shweni, and many other contemporaries. Can you just talk to us? Because it sounds like during that time, in the 70s, Natal, King Edward had some of the best Black gynecologists.
It definitely did. Martin Marvat was the very second one to be a fellow.
Yes.
And the third one, if you take black, was SBP.
Yes.
So the first three black fellows of the College of Obstetrician and Gynecology came from the Natal Medical School, and they were these three friends of mine.
Yeah.
They used to call us three musketeers. We ran that department very well, the three of us. Shweni was a bit younger, but he was a bright chap, Michael Shweni. In fact, I was so fond of Michael Shweni that, I would have liked him to have taken over from me in Medunsa if it was possible. Yeah. I have great respect for Michael Shweni. But for some reason he didn't take it. But doesn't lower my respect for it. He had very many great qualities.
Yes.
And a great fellow you could trust.
As students who came in the 80s, exposed to all of these legends, Prof. Marivate, who had his interest very much around
twins.
Your twin pregnancies.
Yeah, he was the most advanced fellow in that.
Yes, and Dr. Pitso, now I can't remember what his area of interest.
Dr. Pitso was in bleedings.
Yes.
In obstetrics and gynecology.
Yes. Now, so the camaraderie, was there competition amongst yourselves, or but constructive competition in terms of academic performance, research, and things like that?
There was no doubt there was constructive competition. We were always like this. We were about the same age, so we competed quite a lot. And I think this is what built us. I mean, each one wanted to better the other one.
Yes. And so did you continue to just become the deputy of the department, or did you get other responsibilities? I think you mentioned something about Dean of Students at some point.
Yes, when I was our senior lecturer, I was appointed the very first Dean of Students in Natal University.
And what did that entail?
Well, looking after problems of students generally. Sometimes, not so frequently, would be even political, but mainly it was the needy students.
Yeah.
Many of them would come. You remember they stayed out at Allen Taylor,
yes.
And you needed to have money in the pocket.
Yes.
And I became very quickly, I knew what were places to touch. Anglo-American was one of them, the round table. I used to phone these people and I used to beg and I used to get money.
To support this.
Yeah, I became very good at it and I could get money out of them. When I was free, I spent time looking at philanthropic organizations, and get used to them, tell them who I am, what I do need from time to time.
Yeah.
And people responded very well.
So a number of doctors today, even older doctors, actually, were beneficiaries of your efforts.
Oh, they were. Some of them still remember how they tell me how they used to lie. They don't even have a cent when they had cent. And I would always make sure they got some money somehow.
Yeah.
And that used to happen, It's unbelievable how South Africans are philanthropic.
Yeah.
If you really get to them and you give them the problem, South Africans are very philanthropic. They'll give you the money.
Yes, yeah. There came a time, and I want you to help me here, where there was a grand scheme then, and please correct me if I'm wrong, on making Natal Medical School to be a white medical school, Durban Westville to be an Indian medical school, Western Cape to become a colored medical school, and then Medunsa would be for Africans. Yes. Am I right about that?
It's at the birth of Medunsa.
Yeah.
When they thought of Medunsa, these things all came up.
Yeah.
But they were viciously opposed.
Yes.
They were viciously opposed. When I took to go to Medunsa, the idea of Natal going to be close to others was off the record.
Because there was a long strike of many months by students opposing that.
That's right. It was off the what you call. But they really had planned it. It wasn't a joke. That was planned, but it didn't really take place. And when I left, they had agreed that they will not not stop taking black people in Natal.
Yeah.
And that was agreed upon. That was one of the features that people fought me about, but they'd agreed by the time I left.
Well, I'm told that the whole idea came from the constituency of the National Party then, or deep. I don't know what it was, who were saying of the 4 provinces then, Natal was the only province that did not have a medical school for white students.
Yes.
Because there were medical schools in the Cape,
Yes.
2 in Cape Town, there were medical schools in Transvaal, of which Pretoria, Wits, and then in the Free State you had the UFS. But Natal, there was nothing. And so the constituency in Natal were saying, why do we have to send our kids to other provinces for them to study to be, doctors?
Yes, definitely was. I mean, one of the weakest things about South Africa is the color thinking that we have and this type of thing. It's surprising that that thing failed, because it really was, the Natal voice was very, very strong then, that it should become a white medical school.
Yeah. All right. So at what point then did you start to entertain a possibility of leaving Natal and show an interest in taking up the principalship or vice chancellorship of Medunsa at that time of a lot of debates and everything around this grand scheme and everything?
You see, it goes to the true history of how Medunsa started.
Yes, I would like to know that.
It wasn't basically the Afrikaner government that started it.
Yes. Okay, yes.
Leading educationists. Professor Klingo, the late Professor Klingo, was one of them.
Zere. Iklotsa mo Zoom a yele ka 9 ka 7.
Hello?
Ke tsena mo Zoom ka 7. Zoom meeting. Ke wa ke le meeting.
Okay.
Sure.
brothers and sisters. It's so nice to see you again. But right now, I'd like to dedicate this few little words to you. That I've been gone for such a long time, but today, that I'm back one more time. And now, I have a little pretty little young girl with me, yeah, ladies and gentlemen. And I'd like to dedicate this few little words to you. That I've been gone and she's been gone, but now she's back one more time. And right now, I'd like to say, you. Oh, yeah.
It's nearly 1 minute to 7 o'clock. We'd like to say Happy Women's Day. We wish you all the women of the world a very special day for them. And we really thank all Vasadi for being what they are. Was it not because of Vasadi, we wouldn't be what we are. This month of August is a month that we celebrate the achievements that all women achieved and all that we also achieved because of women who brought us into this world through a very painful process of birth, which is delivery, either through cesarean section or through normal vertex delivery. It's just painful to bring a human being on earth. If I was a woman, I would not agree to this notion of gender equality. I would disagree with that. There's no gender equality because I would not agree to be equal to a person who had some time in his life, this stage of his life, he was dependent on my breast milk. I would never be equal to that one. That's why today we are going to discuss the breast, because you all fed from the breast. Before we do that, it would be nice for 2 minutes to 2.5 minutes just to applaud these soldiers, these women who fought so much to keep us alive and alike. Let's just... women, we must really appreciate the existence, the contribution that the women did. Like the greatest man, one of the greatest men in Africa, once said this.
And tell me here, is there a man who can say, I am not born of a woman? Let him raise his hand, let him raise his hand and say, I dropped from heaven. No, we all came through the same road. And for 9 months, each and every one of us was born in that womb, the mother's womb. And even today, when I am struck, say, in my way, I say, oh, am I? Oh, mother. I don't say, oh, father. So the mother is very dear. And it was, and tell me.
Hey, ladies and gentlemen, good evening. I'm greeting you all. My name is P.T. Mahapa. I'm talking to you from the great Limpopo, Polokwane. I'm a urogynecologist here in Limpopo. The topic of today is talking about breast its conditions, which is a problem that women have. We are talking about, when we talk about breast, I mean a female breast, not a male breast. A male breast, I don't know what the function of a male breast. It's a non-functional vestigial organ that a man has. A man shouldn't have had a breast because he uses no breast. It's got no value. Only a woman has got a breast. Some of the functions of a breast of a woman are this one. It's a pride of femininity. When you say this is a woman, you must have nice breasts. It distinguishes your phenotype from that of a man. And it's a center of beauty and femininity in a woman. That's why women, when they dress and walk around, you can see that these are really beautiful women. You look at the breast and the chest, the contour of the chest, which is formed by the breast. It tells you what kind of a person this person is. And one of the functions of a breast in a woman is to breastfeed a baby. Because we are all mammals breastfeed their babies. So only females can breastfeed their babies. The males can never breastfeed any baby. That's why I said male breast is a useless vestigial organ. And again, a breast is a sexual organ. It's got a sensation. It's got sexual satisfaction functions. There are women who can even get orgasm just through breast stimulation. So it's also a sexual organ. Being a sexual organ, I want to say to all women out there that sexual organs are one of the organs that must be kept private. You know, in sexual organs, we have got primary sexual organs and secondary sexual organs. Primary sexual organs, you all them. The secondary sexual organs are things like breast. Breasts are part of the female and male sexual anatomy. When you talk about sexual anatomy in male and female, you're talking about the breast. Female breasts are both functional for breastfeeding and sexual for bringing sexual pleasure. The male breasts, that I've said, they've got no function. Primary sexual organs, we won't mention them now. But secondary sexual organs, which emerge during the puberty, through pubescence phase. For example, we can mention is like breast, pubic hair, the axillary hair, and the facial hair. All women, men should respect female breast. From today, I shall be glad if we can stop emergency tendency of disrespecting female breast as a secondary sex organ. I really find it very difficult for somebody to expose secondary sex organs like this. It doesn't become very much decent, but it becomes unacceptable toward behavior. That you find that a person is dressed, but half of his secondary sex organ is exposed. That behavior doesn't build a humane person. A female breast should be respected and covered like this. You know, there's a condition in psychiatry. I think we are living in a era where mental disorder is acceptable as normal. There's a condition called exhibitionism. The mental disorder. Mental disorder that is even classified in DSM-4 is a psychiatric condition. Exhibitionism, by definition, is an act of exposing in public or semi-public context one's intimate parts. For example, the breast, the genitals, and the buttocks. It's not a thing that one should just do, expose in public one's intimate parts. Like you have said, breast is one of the secondary sex organs. If you expose it, it's regarded as exhibitionism. As a preamble, primary care physician for breast is mostly a gynecologist and obstetrician. Of course, a family physician also has got a role to play there. But no gynecological examination is complete without breast examination. While a family physician might examine some part that you come complaining about without examining breast, and that examination will be complete, especially during reproductive years and after menopause. Most diagnoses of breast conditions, including breast cancer, lie within the realm of obstetrics and gynecology. So your gynecologist should always examine you, make sure that you examine the breast. Breast cancer is one of the leading causes of death in women. Breast should always be examined because it comes subtle, it comes undiagnosed. It should be diagnosed very early, and if it's diagnosed very early, it's treatable. Such that we wish that there must always be continuous education or female education on awareness of breast cancer, screening for breast cancer. All women should know all methods of screening for breast cancer. Every woman should learn the method of breast self-examination, must examine herself, because more than 80% of breast cancers are found by women themselves, are diagnosed by women. The doctor just confirms it. The imaging, which are slightly expensive and not every woman will access them, like mammogram, not always available, but are superior to self-examination and other screening methods like ultrasound. So every woman should have a regular screening for breast, more especially breast self-examination that she must do every month, either when she goes to sleep or during bathing, every time when she baths. What is the anatomy of the breast? Before we discuss conditions of the breast, we should discuss the anatomy of the breast. The breast consists of 3 components. The skin that you see. Under the skin, you've got a subcutaneous fat. The majority of the breast that you see big is just fat. There's breast tissue, which is made out of lobules, alveoli, lobes. The suspensory ligaments are also part of the breast tissue, but the majority of more than 50% of what you see in the breast is just fat. The lobules, they can be 5 up to 10, and the terminating alveoli, that's where milk production takes place, and the milk is collected through the collecting ducts, which are called milk ducts. The sinuses, just beneath the nipple, there are sinuses where milk can be connected. They're called lactiferous sinuses. It does the storage for milk. If you look at the breast, naked eye breast, you see some sauce or some what-like substances on the areola, which are called Montgomery tubercles. They are of no value. They are not just modified sweat glands that have lost their functions. They are found in every woman. So looking at this sinus, you see the lobules here. In this lobe, they've got a collecting duct here, which is a mammary duct, which found a sinus. It goes to find a sinus, and during breastfeeding, milk is stored in the sinuses. And then from there, it can be sucked through the nipple by the baby with the lactiferous duct. Looking at the breast, the nipple is like this. You find these nodules here. These are what you call Montgomery tubercles. They are modified sweat glands that have no function. Even if the breast would function well without the Montgomery tubercles, they've got no physiological function or reproductive function. You can distinguish the breast by having Montgomery tubercles. Normal breast anatomy lies between the second rib, the sixth rib. You count your ribs, the second rib onwards to the sixth rib, on the chest in front, be a breast. Laterally, it comes from the sternum up to the middle of the axilla, up to the mid-axillary line. From the second rib up to the sixth rib, from the sternum up to middle of the axilla is the breast. In some people, there's a breast extension into the axilla, into the ampulla, and the armpit itself. That tail is called axillary tail of Spence. Some people, when they do breastfeeding, find that in the breast grows inside the armpits. We'll see that when we discuss the development of the breast, how it comes. Normal breast in a patient who has, in a woman who has never given birth to a child. That's called a nadiparous woman. It's conical, looks like a cone, as we see it here. But once a woman delivers it, becomes pregnant and have a baby, and the breast secretes milk, it starts to become pendulous. As you secrete milk, whether it was pregnancy time or not, once the breast can secrete milk, even if it's a miscarriage, the breast will start to become pendulous. As it becomes pendulous, you see that these lobules will fall down, and lactiferous sinus will become more enlarged because you once contained milk. Let's look at the anatomy, the developmental anatomy of the breast. During embryology, about 8 to 12 weeks of life, which means 8 to 12 weeks after fertilization, there's an area of an embryo which is called mammary ridge, the ridge of the breast. Along that mammary ridge, there are several buds that develop along the ridge. Mammary ridge extends from the armpit to the groin. Both sides, there are 2 mammary ridges. Along that mammary line, there are breast buds developing. So these breast buds, if you can imagine the breast of a pig, a dog, you find a series of breasts underneath on the mammary line. We were developed like that. We were human beings initially as an embryo. He has got a lot of buds, breast buds along the mammary ridge. But some of the buds, they disappear. They undergo the process called atresia. Only the thoracic buds develop, only 2 of them. That's why you've got 2 breasts. It's only in some people that the thoracic buds do not develop. Embryologically and genetically, we are from the same family as pigs and dogs. We should have breasts all along, but because of evolution, other breasts they regress. That's why you find sometimes in some women, you find along the mammary line, you find that a person has got accessory breast, right below the breast in the armpit. That breast might be a full breast which is functional, or it might just be a nipple. Like here, this woman finds that she's got a nipple somewhere. This nipple may develop from the ampulla, from the axilla, below the breast, up to the groin. You might have a breast there. If that breast becomes accessory breast, the breast tissue, screening for breast conditions like cancer and tumors of the breast, you must also screen for that. Most especially the common site of accessory breast is in the armpit. Stages of breast development, we should know them before we come to breast condition. We should know how breast development. 5 stages of breast development. They are called Turner stages. Mr. Turner described them. Stage 1, preteen, in the teens or the preteens, only the tip of the nipple is raised. The whole chest is flat. Stage 2, which is about 9 years, buds appear. The breast and the nipple are raised. They start to be raised from the skin on the chest, become bud there. The dark area around the nipple, the areola, becomes larger and visible. In our mother tongue, we say, that's when is puberty are coming. That's stage 2, Turner stage 2. And then from there, stage 3 It's when the breast becomes larger, he can even ask you to buy a bra. The glandular tissue become present. Stage 4, like an adult breast, but the only difference is that the nipple and the areola are more raised than the breast tissue. Until the mature adult breast, which is stage 5, which the nipple and the areola are at the same level, but the breast now is fully mature. If it's nulliparous, it's conical. If she has never given birth, breast will become conical. If she has given birth, it will be pendulous. This is the different stages of breast development. Stage 2 is when only the buds develop. And you can look at the stage 4 and stage 5. Stage 4, the nipple and the areola are raised. Stage 5, the nipple and the areola are at the same level. That's the different stages. One would wonder, nulliparous, who have delivered for that with the breast that is pendulous. As time goes on, whether you delivered many times or not delivered many times, the breast will sag. Breast sagging. It will move. It's like the breast is moving from up in the thorax down towards the abdomen. That's called ptosis of the breast. We find that it's more towards the umbilicus than it used to be before. Because of the lengthening of the suspensory ligament of the breast, because of the weight of the breast. The heavier the breast, the more the sagging, because those suspensory ligaments, they lengthened the breast sags. Sometimes the breast can go and even reach the level of the umbilicus. You can look at this woman, the breast is almost at the level of the umbilicus. These are the type of women that usually will go and ask for breast reduction or mammoplasty, because breast sagging usually, even the bra, when you put up a bra, it got pain on the shoulders. Some breasts can become so heavy that the bra will irritate the woman on the shoulders. So because of the breast ptosis. We need to understand better changes before we go to the breast tissues. When a woman at about 9 years around puberty, she developed the first breast development. It's called thelage. Thelage is the development of the first breast development. That's stage 2. And now that's when wana atoka matswele. There is adrenage, which is about 10 to 11 years, which is development of axillary hair. The hair in the armpit start developing. Then come pubake. Pubake is development of the pubic hairs, which is more or less developed at the same time as adrenage, the development of the axillary hair, the armpit hair. Then come menarche. Menarche means first menstruation, which usually is between 11 and 16 years. Every woman, it can reach up to 18 years before you menstruate. We call it late menarche. Those who menstruate about 9, 10 years is premature menarche. Then come petake. Really, I looked at the books. I don't know what's the first age of petake. No books know what the first age of petake, which is the first sexual intercourse, because ideally should be after woman has developed, has attained maturity, financial maturity and mental maturity, which is way above 21 years. But in South Africa, we are changing science, you know. Find a woman who have got coitaque before menarche, for 9 years, you already have first sexual intercourse. This is what we as women in this Women's Day, we must try to change and maintain that coitaque happens when a woman has reached mental maturity and financial stability. I find it very much odd that the government can even supply condoms to school, primary school. For what? Because there shouldn't be a need for those at primary school. But well, we are living in a mad world. The breast has got many conditions that can develop in the breast. And once a person has got a condition in the breast, what's ringing in her mind, she thinks is a breast cancer. There are a lot of conditions that can happen in the breast that are not breast cancers, but we always suspect the West in any situation, which is good that we suspect the West rather than to think it's something benign while it's the West. The history of that condition which is in the breast will give you a diagnosis. The history by the position of the nodule, the number of the nodules, whether it's one side or both sides, whether there's nipple discharge or there's no nipple discharge. Give you the clue whether this can be cancerous, it can be benign. The pain also, some conditions of the breast are painless, some are painful. Cancers also, when it starts, can be painless and later it become painful. The nipple, does it retract the nipple? The size of the color over that, is it changing or not? Because if it's inflammatory condition, the color will change. In the cancer's color might not change. Is that mass nodule mobile or fixed? And if you touch it, what's the consistency? Is it soft or hard? A lot of characteristics of a lesion in the breast will tell a clue whether it can be a benign lesion or it's a malignant lesion. We see here, we can have abscess developing in the breast from infection. We have abscess which can burst into the skin and even form a sinus. We can have benign tumors. Benign means non-malignant, not cancerous, like fibroadenoma, which most young girls have. Fibroadenoma, they think is cancer. While cancer of the breast is very rare, below 35 years. You might have cystic lesion, which are cystic, can develop in the milk ducts if they block and the secretions accumulate there as fluid and form a cyst. You can have a condition called mammary dysplasia or fibroadenomatosis, which would differentiate from fibroadenoma. It's nodular, but it is benign. It's not cancerous. You can have tumors of the breast. We'll discuss some of this briefly. As I said, tumors of the breast can be benign. Benign means not cancerous. It's a tumor. It will never kill anybody. It will just be there. It might cause pain. It might not cause pain. You might leave it there. It might grow. It might not grow. You might remove it. You might not remove it, depending on the behavior. It can be malignant. Malignant means cancerous. But we'll discuss benign tumors first. And tumors can come from the epithelium. Epithelium usually of the duct system. It can be the epithelium of the alveolar, or the epithelium of the lobes themselves. It's called epithelial tumors, or it can be fibrous, the fiber that forms this fibroepithelial. It contains fibrous tissue and epithelial tissue in it, histologically when examined. It might be a tumor from the muscles, and the epithelium is called myoepithelial tumors. But it can come from the connective tissue in the chest, which will be superficial connective tissue, which are called mesenchymal tumors. Nipple also can have its own characteristic tumor, which usually in the nipple we find dermatological tumors, which are the skin tumors. The inflammation, either from infection or from trauma, will also occur in the breast. If inflammation is from infection, if the infection is bacterial and pyogenic, you have breast abscess, which is called, or the pyogenic mastitis, where you've got a tumor, swelling of the breast. If you milk it, you find pusty substance coming out. That's why if a woman is breastfeeding and has got pyogenic mastitis, stop from breastfeeding, because that child will suck the breast that has got infection or cells inside them. Or the breast might be injured. If you get injured, as I said, majority of the issue, what makes the breast is fat. You get fat damage, and fat, when it gets damaged, it becomes necrosis. Then you get fat necrosis, which might be painful. Or you might get what we call fibrocystic disease of the breast, or cystic mastopathy, which is a dysplastic condition that happens in the breast, which is not fibroadenosis. It's also mobile like fibroadenosis, but consistency differ because it's not smooth, it's rough. It's common also in young people. Or you might have galactosale. All these conditions are not cancers, and they are so common in young girls less than 35, such that you find the mother bringing the child and say, she might be having breast cancer. It's not, but you must exclude blood cancer. Or you might have galactosale. Galactosale is collection of the milk duct forming a sinus in a woman who was breastfeeding and later is not breastfeeding. During breastfeeding, one of the milk duct got blocked and the milk accumulated there and formed a galactosale. we might get a condition called hypertrophy of the breast, which is just excessive growth of breast cells, the fat, the mesenchymal tissues, the glandular tissue just hypertrophy and become big, and that breast becomes what you call giant hypertrophic breast, like you see in here. This breast doesn't have a tumor; it just each cells just multiplied, and woman has got a big breast like that one. And this breast hypertrophy must be differentiated from mammoplasty. A woman who doesn't have hypertrophic breast just have big breast by nature. People have got different sizes of breast. A hypertrophic breast is large; it can go up to the thighs. But if a woman has got a large breast, it doesn't mean that it is hypertrophic breast. One should differentiate that. Most women that we see around, they just have big breasts, but no hypertrophic breast with them. So don't diagnose every woman with a big boobs that she has got hypertrophic breast. One characteristic that we need to look at in the breast, the pain nodularity of the breast. If the condition is painful and the woman is less than 35 and is a nodule which is painful, the chances that that cannot be a cancer. It's not a cancer of the breast. The probability is that it's not a cancer. But if it's above 35, the probability is that it can be cancer of the breast. So the age of prevalence of cancer of the breast cutoff line is 35 years. So you must look at what kind of age is the patient presenting with a nodule. Because there are many conditions on the chest. Some of them are the chest conditions, some of them are the breast condition that might mimic cancer of the breast, then behave like breast of the cancer, like pain in the heart. Cardiac pain might just be felt in the chest, and you think it's pain in the chest, pain in the pleura, on the lungs, thoracic bones, spondylosis, may cause pain, which might just, the woman will look at the chest and think at the breast, you think it's in the breast, when actually pain is inside. But also some condition like tachycardia. Tachycardia is a condition where the milk duct become stenosed, the secretion accumulate there and cause pain. And as I've said, damage of fat with trauma or injury to the fat tissue of the breast will give rise to necrosis, which is a painful condition. Sclerosing tumors, which becomes sclerous, can be tumors. But all these are not cancerous, they're not malignant, they are benign. So only if it's over 35, we must start, investigation must be start, we must exclude cancer. Very rarely, under 35, conditions in the breast can be cancer. So if you've got a young teenager who's got a breast nodule, you must know that it's one of those that we mentioned. It's not a cancer, chances that it's not a cancer. But the doctor, to play safe or to treat you psychologically, might do tests that exclude cancer of the breast, but it's not necessarily always necessary. These are benign tumors of the breast that I can mention some few. I'm starting with benign things to teach you that not common things that happen in the breast are cancers. The woman, because the way we are so afraid of cancer, once he's got some nodule in the breast, oh, doesn't sleep. Cancer, it's not cancer. That's why we start with benign tumors of the breast. The commonest one is called fibroadenoma, which is a firm mobile breast nodule. You go and touch it, it moves around. It's also called a breast mice because it's very loose in the breast. One is ductal papilloma. Ductal papilloma is notorious that it behaves like a cancer. It's got a bloody discharge. The breast blood discharges blood, while also in the cancer, the breast will discharge blood. That's why women will think that once she's got a bloody discharge, they think it's cancerous, while it's breast papilloma. Ductal papilloma very rarely above 35. It can even happen above 35. That's why if you've got a watery or bloody discharge in the chest, let that discharge be examined. If there are no cancer cells in the discharge, you must know it might be a ductal papilloma. Then you become happy. The treatment is very successful. The fat tissue of the breast also can have tumors. Tumors of the fat are usually called lipomas. You find a nodule on the breast, The breasts are not even of equal size because the other one has got nodule, 1 or 2 nodules. You think it's breast cancer, the biopsy comes or ultrasound is done. They say it's just fat, be satisfied. Fat tumors are very common on the breast. As I've said about cystic lesions, the cystic lesions are in the milk ducts, they contain fluid, usually it's oily fluid. If they're with a needle and look, the fluid becomes oily, oil of a cyst. Usually the aspiration alone treats it, but if it recurs, it might need to be removed surgically. The lymph nodes in the breast also can be enlarged. Some other primary lymph node lesion tumors, which might be infection or it might be cancerous, and a biopsy will confirm whether these are lymph node tumors or it's because of metastasis from infection somewhere or cancers. Because you know all lymph nodes somewhere, we used to call it gritaka. If there's infection somewhere, the draining lymph nodes get enlarged. It's a means of fighting that infection so that it mustn't spread all over. Women usually, they've got children, usually whether boys or girls, they've got mastitis of infants. You find that a child of 2-3 months has got milk secretions. And the old women say, hey, what is this? Milk, what? They start to scold the mother because they say the mother is engaged into sex before time. Those are all fallacies about it. It's just that in pregnancy, there's a lot of increase of female hormones, especially estrogen. So in the milk, if the child sucks milk, which has got high estrogen level, it might just inhibit the prolactin secretion, and she's got that milk. It's called witch milk, which is self-limiting. You just leave it and continue breastfeeding. But as the child grows, it won't affect him. Of course, infection will give you abscess and pain and all signs of inflammation that we showed before. Trauma would give you fat necrosis. We have discussed that. Those are benign conditions of the breast. The common one that I want to tell people is intraductal papilloma. We said it was ductal papilloma, that one. The one that I said it gives water discharge. It's small, smaller than a cancer. One is experienced in examining a breast, you'll see that tumor is usually smaller than 2 centimeters. It's non-cancerous. And it grows only the male ducts. Once it's in the male ducts, it will be superficial. And the best approach for it is for your doctor to cut a biopsy there and go and confirm in the laboratory whether is it a tumor that needs wide excisions or not. You take a small part of that tumor, send it to the laboratory, examine, because it might involve a single duct or many ducts. If you are unlucky, it might involve both breasts. You find that you've got intraductal papilloma in both breasts. But God is not so cruel. It doesn't give usually disease in both breasts. It would be one breast majority. Even breast cancer usually occurs in one breast. Because it produces milk secretions or watery secretions, investigations should be done to exclude other conditions which are not tumorous that produces milk. There's a condition called prolactinemia, the tumor of the pituitary gland which secretes a hormone which is called prolactin. If the hormone prolactin is secreted, then you've got milk secretions. That's what causes one of the causes of infertility and amenorrhea. If a woman has got secretions, she has stopped menstruating, you must know chances are that it's prolactin that causes that secretion. It's not a tumor. There's some treatments, many drugs, most especially antipsychotic drugs for psychiatric patients, the phenothiazines and terpenols, but if taken for a long time, one of the side effects is milk secretions. You must exclude that in a woman. The treatment of intraductal carcinoma, if biopsy is taken, is confirmed as intraductal, it's just conservative and reassuring the woman that this will not going to kill you and go on with your life. It will just stay there. It won't kill you. It will never, doesn't change. It very rarely change you into a breast cancer. Continue screening because it doesn't mean you've got intraductal carcinoma, you might not develop breast cancer. Some women, because they read so much about breast cancer, they come to the doctor so many times complaining about that innocent tumor, so that Surgeon, the doctor will even have to do a surgery and remove it just to allay fear and anxiety, because it does help a woman is anxious. Every time she hears somebody's got cancer, she thinks she has it. It will keep on coming. So if you remove it, maybe you treat the woman psychologically. Most women, most surgeries that are done for this is to treat the woman psychologically, but it's not cancerous. It's like cyclic mastalgia. Majority of women during menstrual cycle, those who are still in the reproductive age, they've got breast enlargement, breast engorgement, and which sometimes can be painful. The pain may be seated, it might be around the areola or around the nipples. It's always bilateral pain. And if it's bilateral and it is cyclical, like menstrual cycle, usually in the second phase of the menstruation towards bleeding, it's just mastalgia. It's from the hormones changes that happen during menstruation that it engoys the breast. Its breast is swollen. It's got no nodules, no tumors inside, but the whole breast becomes swollen. You find that the woman might have two sizes of bra. Maybe it's put in size C and B. Early in the cycle, size B. The cycle goes to menstruation, size C, bra, because of breast changes, which is called cyclic mastalgia. And the women think it's a breast cancer. It's not breast cancer. And usually the swelling become on the outer upper quadrant. That's why it needs to change in the treatment of cyclic mastalgia. Usually it will be there. If it's in a woman, it will be there. It will only be there when the woman is not menstruating, which is during pregnancy and after menopause. And the reassurance and education, why is she feeling like that? It's enough, the woman, rather than to go on deep, expensive investigation, which will nothing. Even the investigation, if you do mammogram, you do ultrasound, it's just to allay anxiety and exclude other pathologies. Because if you don't examine, just on symptomatology and history, she's not going to be satisfied because she has heard about this condition that kill. Sometimes hormonal treatment can help, most especially oral contraceptives. If they can stop menstruating, they'll stop that. Majority of it is self-limiting. If it goes away, it's not because of the doctor's drug, it's just self-limiting. Ectasia. If there's inflammation around the duct, it's called, it compresses the milk duct. If the milk ducts are compressed, then you have dilatation or constriction of the ducts. And if the ducts constrict, the proximal part is what you call duct ectasia. Duct ectasia can be a very painful condition. And there's a sticky discharge from the breast. This sticky mucus discharge is never bloody, because there's a palpable mass which is painful and itching around. Investigation that either you exclude fibrosis, which is necrosis, or exclude fibroadenoma. If you exclude that and you have excluded cancer through mammogram or biopsy, treatment is just observation and treat the inflammation. Cytology of the discharge, if you take it just to exclude the cancer, you exclude the cancer just for academic purposes. Because if you look at the milk duct here, if it is a normal milk duct size, duct ectasia, because there's blockage there, there's enlargement of the duct that form a tumor. And usually it's towards the nipple, where the milk duct is clogged and milk accumulate there. Benign tumors, by definition, are called adenomas. Benign tumor called adenomas, it can be very large sometimes. It's so large that they worries even the doctor and the patient. And it can be multiple or single, you never know how many. And they're mostly movable, especially fibroadenomas. If the breast is like this, if the solitary is around, you'll have round, smooth edges. You'll find that you've got round, smooth edges of the breast. Those round, smooth edges of the breast, on ultrasound, you can even differentiate it from other tumors of the breast. It's a fibroadenoma, which is, I said, is the commonest tumor that happens in adolescents. The other tumors that can scare people is the tumors like and fibroadenomas. And fibroadenomas sometimes can cause ischemic necrosis around the skin, even form a wound that will look like a fungating, like it's a cancerous wound, while it's just a fibroadenomas. Cystic breast disease, also 35 years is the of life. If you are less than 35 years, you are unlikely to have cystic breast diseases. They usually smooth and they are filled with fluid. If you touch them, fluctuant. They are painful. So anything painful in a woman, things of a cancer. If you are white-skinned, skin around the cyst will be bluish. If you are black, like most black, there won't be any change. And the discoloration of the skin will not be there. Then the only way to differentiate it is either do ultrasound, you find that this is cystic or solid, or you aspirate the cyst. But the mammogram is very good in differentiating cystic lesion from solid lesions. If you look at a picture of a cyst of the breast, which might be singular or multiple, you see a normal breast and breast with cyst. If a white-skinned, bluish, because they contain bluish sticky fluid, it will be blue. The color, the skin color will change to blue. But as I said, in black people, it doesn't show. Breast fibroadenomas, which are the common tumors that happens in young people, which are not painful. One thing about difference between intraductal papillomas and mammary dysplasia with fibroadenoma is that those two are painful. This one is not painful. If somebody comes with fibroadenoma, a young girl comes with fibroadenoma and says it's painful, that pain is psychogenic, it's in the head, it's not in the breast. And the majority of them, you ask them, they say, is it painful? They say, yes, it's painful. It's not painful. It is just that they've got this psychogenic pain because they fear the West. They're highly mobile. That's why it's called breast mouse. You try to touch it, it moves from place to place. You cannot just locate it. It doesn't stay one place. One thing about the difference between fibroadenoma, intraductal carcinoma, is that this one it's got a potential of changing into a cancer, but it's very little chance. 5 chances can become malignant. So whenever you diagnose a fibroadenoma, remove it. No place for conservative management. There's no way to know which one has got this 5% chance of becoming cancerous. Once it's a fibroadenoma in a young girl, less than 35, remove it. Because of those little chances of 5% of becoming cancerous. The only thing is that it can be an emergency because of the chances of malignant cell formation are less. Although, because I've said 5% chance of malignancy, which means 95% of fibroadenomas that are moved to be benign, will not be malignant. What scares mostly is what you call giant fibroadenoma, which is called cystosarcoma phyllodes. A very rare condition. If it happens, it scares a woman a lot. Looking at this scar, we see a woman with multiple fibroadenomas, which we map them before we operate. You operate them, you can remove small little nodules from the breast. These are the ones that left, they've got 5% chance of becoming cancer. So if we diagnose it in a young girl, it doesn't matter if she's 13 or 14 or 15, remove it. We exclude those chances. The giant fibroadenomas, cystosarcoma phyllodes, behave exactly like fibroadenomas. They've got a chance of becoming malignant. If left for a long time, they become so big that they can make the woman cachexia. This one probably has become malignant, it's become cancerous. That's why the woman is thin, because cancer is a highly metabolic disease. It makes a person very thin. And on ultrasound, if you look at fibroadenoma, I've said the edges are smooth, like the mammary dysplasia or fibroadenosis. are not smooth, they are rough. This one will find smooth edges, and it's usually peripheral in the fat. It might be one, it might be two. If the woman is unlucky, it might be bilateral. Mammary-ductectasia, I've said it, it is one of those lesions that produce milk, and there's a pin in them, and it may simulate breast cancer, but it's not a breast cancer. Only by biopsy you can be able to differentiate it. With ductectasia, one thing about what causes pain is that as the fluid accumulates inside the milk sinuses here, it becomes so much that the duct bursts, and if it bursts around it, there's bleeding with the bursting of the duct, there's inflammation. If there's infection, you form an abscess. That's the danger of ductectasia. If left alone, it's going to burst. Ductectasia, why it stimulates cancer? It stimulates cancer because it also causes milk discharge. The woman finds that she's got milk discharge, which is not there because of prolactin secretion. It will still be menstruating, or it might be bloody discharge while it's non-ductectasia. The only difference that will tell you what will happen in a cancer, which does not happen in ductectasia, is the nipple retraction. The nipple will never retract. In a cancer, the nipple will retract if it's superficial next to the nipple. Ductectasia doesn't. And now, ladies and gentlemen, we are going to what interests everybody. All that we have talked about, not cancer. Only fibroadenoma has got little chances of becoming cancerous. Discussing the breast cancer, the most feared condition of the breast, which might happen in the fat of the breast, in the lobe of the breast, in the lobules, or in the ducts. The different types of breast carcinomas. Either is a common malignant condition of the breast, different types of them, and each one has got its own virulence. They are not all equally dangerous. The second most common cancer in an African woman. First common cancer in African woman is cancer of the cervix. The second commonest is cancer of the breast, and vice versa. The commonest cancer in white population is breast cancer. The second commonest cancer in white population is either cervical cancer or lung cancer, depending on where the woman lives. Because in Europe, women smoke like men, so the lung cancer becomes more common there. But why Africans, you have got more of cervical cancer than breast cancer? Because breast cancer, the risk factor are the same both in men and women. Because Africans, that you like it or not, cervical cancer is a sexually transmitted disease. I think Africans were the most promiscuous nation that you can find under the sun. So cancer of the cervix is more common in us than in white population, because we engage in early sex, unprotected sex, and faithful sex, and other things. So whites don't do such things. You never see white children queuing for grants or becoming pregnant in primary school. It's only black girls that do that. That's why we've got breast cancer second than white. When you say something is malignant, I want to describe it. It means it grows uncontrollably. You can't control it grows, and it's got the ability to metastasize. In CCPD, you find that you've got cancer in the breast, but suddenly there's another cancer. That cancer has moved to the lungs, it has moved to the heart, it has moved to the kidney, but it's from the breast. It moves around. The which are metastasis, it can metastasize. And one cancer, the breast can be found already metastasized to other organ. That's end-stage disease. Treatment is just to prolong illness life. You know that woman in the near future will be killed by breast cancer. That's why screening is very important, so that it can be found early while still local, and it can be removed completely. If you found early, it has to metastasize. It's a pity. It's not only in the breast, it's in the other organs. You'll treat the one in the breast, the one in the other organs will also move around the whole body. It becomes a systemic disease. Then you know that treatment is just palliative to let you finish the last few months or few years of your life painless, but you know that at the end you're going to die of breast cancer. The risk factor of breast cancer, I've said there's the same in black and white, the demographic, the lifestyle. Lifestyle of a black woman now is the same lifestyle of a white. We don't have different lifestyle. Diet, we eat the same diet. Reproductive behavior this way. Whether you have children early or you menopause late, because breast cancer depends on the duration of exposure to estrogen. So you find more breast cancer in women who have never been pregnant, a woman who have had early menarche, a woman who have had late menopause, they've got breast cancer, because breast cancer is an estrogen-sensitive tumor. It also runs in family. There's a genetic component in breast cancer. If your first degree relative, your mother or your sister has had a breast cancer, you've got more chance of having a breast cancer than the other person. The family history goes in this way. If you've got a family medical history, I mean your history, your medical history, you've had, say, fibrinosis, breast mouse, you know that you've got a chance of developing a breast cancer, because fibrinosis has got potential of transforming into cancer. Let's just explain menstrual and reproductive history, that the early menarche and late menopause increases the duration of exposure to estrogen. That increases the chance of developing breast cancer. Reproductive history. Woman who's got no child, which means she has got no moment where she was not menstruating, or during pregnancy, menstruation stop for 9 to 12 months. During breastfeeding, menstruation does not occur during breastfeeding. So if it's continuous cyclic menstruation, the chances of developing breast cancer are higher than those who have got children. So the more the number of children, the less the breast cancer. Why? I said that, or I'm going to say that breastfeeding decreases the likelihood of one developing breast cancer. So if a woman delivers, must be encouraged to breastfeed so that she mustn't develop breast cancer. Some diet and fat and sugar and alcohol are also implicated in breast cancer, but not so much of it. The value of, because I said estrogen, breast cancer, breast tissue is estrogen sensitive too. Now the question will arise, hormonal contraceptive consist of estrogen and progesterone. Are they having positive effect on the breast cancer development? There's no clear answer to that. But the amount of hormones that are there in hormonal contraceptives are so little that they're even less than the one that the woman has estrogen from her own ovaries. And when you look at the risk benefits, the benefit of hormonal contraceptives far outweighs the risk of breast cancer. You cannot withhold hormonal contraceptives because you fear breast cancer, because you've got more benefits in hormonal contraceptives, and the amount of estrogen in there is very little that you can ascribe to that. It's even smaller than a woman during pregnancy, estrogen level. I would say, what about the breast cancer during HRT, hormone replacement therapy, and breast cancer? Although many studies, WHY study especially, it confused the situation. It confused the management of menopause, because it came out that there were increase in the prevalence of breast cancer in women on certain types of HRT, especially estrogen only is HRT, which we give the woman has removed her uterus. But if it's combined HRT, which is progesterone and estrogen, which we give when a woman still has a uterus, it doesn't have effect on the breast cancer. Actually, the hormonal contraceptive and HRT combined, it's found to have protective effect on cervical cancer and ovarian cancers. So there's no dogmatic answer that you can say that this cause or doesn't cause. But now, why we still have to give it weigh risk-benefit ratio. The benefit of HRT about outweigh the risk of developing breast cancer. So you must still give a woman HRT. What about the role of ionization, radiation? Mammogram is radiation. radiation causes cancer in any way. It's only high dose radiation to cancer. If it's brief and transient, like in mammogram, in low dose, chances of it causing breast cancer is far less than the benefit of mammogram far outweigh the risk of radiation, because mammogram can pick up cancer at a very late age. So what you benefit out of that? It outweighs the risk of radiation. But radiation, extreme radiation also causes cancer, of course. The summary, late menopause, I've just mentioned it, that it increases the chance of developing breast cancer. Childlessness or having the first child after 30 increases the chance. Not breastfeeding increases the chance. Family history of breast cancer. Or increased fat. Obesity after 35 years, it goes this way. When fat metabolizes, one of the byproducts of fat metabolism is estrogen production. There's peripheral conversion of fat into estrogen and increase estrogen production. So it can increase the amount of estrogen to the level that you can have estrogen level equal to normal woman who is in the reproductive age. So you must encourage women to breastfeed. You must encourage them not to have children very late. Of course, that's from a health point of view. So from economic point of view, it's not wise to have a child. And then you discourage obesity, which is caused by lack of exercise in any way or consumption. Those are the risk factors for breast cancer. If a woman has got one of these, she's got the chances that he will develop breast cancer. But I must emphasize that women should breastfeed their babies. There are many benefits of breastfeeding: prevention of ovarian cancer, prevention of cervical cancer, prevention of breast cancer. There's a lot of benefit. It's a whole textbook on benefits of breastfeeding. Psychological benefit, in between you and the baby, delayed menstruation, contraceptive benefits. You can list them. There are many benefits of breastfeeding. Already discussed the breast cancer and hormone replacement. I told you that there's no risk benefit. The risk of not taking HRT, you are risking osteoporosis, you are risking spinal compression fracture, you are risking that you're going to have forces like this. If you've seen old women when they move around in town, they are bending like this woman. We used to think this is a white man's disease. Of course, it's a disease of a person who doesn't do much exercise. And I ask you, what's the difference between a white and black woman now? They're all the same, man. They've got people who are working for them in their houses. They hardly do hard work. They can't go to the field. Don't carry their children in the bag. They're just the same. When a woman is seated here, is watching a TV, it's even lazy to go and change a TV. He's using a remote control. And he goes to the nearby cafe, he's using a car. We have got the same lifestyle. So we're going to have osteoporosis like this. So HRT prevents osteoporosis. So the benefit of HRT outweighs the risk of breast cancer. As I've said, with all our contraceptives, I've already told you that you must have the benefit outweighs the risk. So it's important that you must take oral contraceptive if you, as part of family planning, if you want to plan family. Screening and detection. That self-examination is the cheapest. And women must be taught how to do breast self-examination. Mammogram, you must do a mammogram, which is an X-ray examination from the age of 35, because I've said that cancer starts at 35. From 35 to 50, it's encouraged that you do it every 2 years. After 50 years, every year, because that's when the breast cancer rate steeps up. If you have got breasts, so you're putting a size D bra, self-examination becomes difficult, because if the breast is big and you examine it, tumor is deep, you cannot feel that breast. Even mammogram has got penetration, it cannot penetrate very, very deep. Ultrasound also cannot penetrate very deep. The the problem of changing center of gravity and baby caused by big breast, it becomes very difficult to detect breast cancer if the breast is big. So it's important that if the breast is big and the woman is worried that she might have cancer, if it develops cancer in a big breast, it will be discovered very late. The woman should rather be encouraged to go breast reduction or otherwise, because screening methods are not as effective as in thin people who have got a small breast that ultrasound and mammogram can see, examine. So what I'm saying is that the big breast, all these tests that I'm doing are not much useful. So it's important that we must encourage women with big breast to do breast reduction, mammoplasty like this, and reduce the breast tissue. If they reduce the breast, they've got added benefit of beauty and pride. And they've got added benefit that they are easily screened if there's cancer in BC. You can see this woman has just done breast reduction and it is good. So in that way, if breast is reduced, you can do a self-examination and pick up the tumor very early. Let's talk about self-examination. Although it's Women's Month, we talk about women. Self-examination doesn't not only involve women. Of course, female must do breast self-examination monthly. And vulval self-examination monthly. That's mandated. Every woman should, every month, once it's birth, you must palpate her own breast and see if there's nothing. If you palpate it every month, you'll know how your breast looks like. You'll see the changes. You must take a mirror and look at the vulva. What the labias look like, what the things looks like, whether there's something there. If there's any change, you can be able to see it, because vulval cancer is one of the cancers that is very early and is concealed. Of course, a man must do some self-examination, testicular self-examination, touch your testes and see if they're still the same as before. Are they nodular? Are they painful? Are there varicose veins around them? Are they retracted or what? And even the penile examination must examine the penis every time. And I also say that by cross-examination is important. A woman must examine the man. The man must examine the woman. The man must examine, when you touch the breast of a woman, whether during the sleeping or foreplay or anything, feel for things that are not normal in a normal tissue. Sometimes the husband can be the first one to diagnose a tumor in the breast. Even the vulva, don't be ashamed to look there and say, let me check how things look like, because sometimes it becomes difficult for a woman to look into the vulva without a mirror. And vice versa, the woman must examine the man. Let's see whether you have got tumors or what. And even the testes, when you test them, examine them. A couple should examine each other and teach each other this self-examination technique, because it is important part of sexual health, genital and self-examination. And a woman should learn this technique. Vulva, vagina, cervical, and rectal examination usually are very difficult for someone to do by herself, be done by the doctor. But the partners can also do that if they are well taught. So it is important for women to learn early on what's normal for their breast. The breast can look very different from one woman to the next. So everyone should know what hers looks like. If a young woman begin performing self-examination early, will become aware of changes that can occur in that breast. And if changes occur, she can consult early and treatment can be instituted very early. Self-examination is very important because it can detect early cancer, which is curable. Self-examination of all organs that I've mentioned. Anytime, but especially, I think the best time is when you bath. Ideal time is when you bath. When you bath, examine your breast. And you notice any change, consult. If it's benign, we're happy. If it's malignant and it's early, it's curable. You can be treated and cured. When you self-examine the breast, of course, when you bath, will be exposed. If you are not doing during bathing, expose yourself and examine with both hands. The left hand, examine the right breast. Right hand, examine the left breast, and vice versa. It is important if you are sitting in front of the mirror, or sometimes when you are sitting supine lying on the bed, you examine all four quadrants of the breast in a rotatory manner. These are the little pictures of why you can examine the breast. You can sit in front of the mirror and look forward and see whether inspection at the breast is the same level. And when you raise your hand, the breast coming up the same. If there's a tumor, another one will be tethering, another one will go higher than the other. If you clench and squeeze your chest muscles, which are the pectoral muscles, put your hands on the waist, what happens to the breast? Does it stand up or remain as it is? Many maneuvers. I advise that it's advisable that when you examine, go in a clockwise fashion, because on inspection only, you can suspect something. Then from there, you can go to palpation. As I said, more than 70% or 80% of breast cancers are diagnosed by the patient themselves, the women themselves. The doctor just confirmed the diagnosis. If a woman would, all women would be taught how to do breast self-examination, no woman will die of breast cancer, because we will diagnose it very early and treat it very early, because the woman would have seen it early. So the self-examination is a very important part of sexual health in every woman. But before you do self-examination, you should know signs and symptoms of breast cancer. Signs or symptoms of breast cancer varied, but they're clear-cut. Thickening, any thickening on the breast can be a breast cancer. Any swelling on the breast can be a sign of breast cancer. Any pain on the breast can be a sign of breast cancer. Any secretion on the breast can be a breast cancer. As I've said, breast, the milk line during embryology, it extends from the armpit. Any lump in the armpit can be a breast cancer. So if you've got a lump in the armpit, exclude breast cancer. Any breast mass which is irregular can be a breast. If you've got a breast mass, you look at it, it's not smooth, it's irregular, can be a breast cancer. Any lesion inside the breast that causes skin dimpling or skin discoloration or nipple retraction, or deviation of a nipple from a normal position, is likely to be a breast cancer. Irritation or pain in the chest might be indicative. As I've said previously, there are other chest conditions that can mimic breast cancer, but you mustn't just ignore it, most particularly if a woman is above 35. Redness in the area of the nipple will be a nipple cancer. Inflammation can also give that, but it's important and safer to exclude breast cancer. Such as nipple retraction and nipple discharge, of course, is a given. Breast cancer. When you sit in front of the mirror, you see one breast is bigger than the other. Suspect there might be a pathology inside that breast. If you're above 35, go for mammogram, go for ultrasound, for self-breast examination. Let the doctor or a nurse examine you. The investigation be done. You might be cured and you become a breast cancer survivor. It mustn't forgotten that if a woman has got a lesion in the breast, must be examined whether she doesn't have other accessory breast from the armpit on the milk line to the groin, because you might find that the woman has got accessory breast or accessory nipple here, which can also, although very rarely, develop cancer of the breast. That's why it's important when they examine your breast, you'll also go into the axilla and they tickle you, you laugh, you think they're making you laugh. They're feeling whether there are nodules there, they're breast nodules or lymph nodes, because breast cancer metastasizes from the lymph nodes. These are just the pattern of breast self-examination, clockwise and concentric cycles, or you can go in a wedge pattern like this, or in a clockwise concentric cycles like that, or depends which one you feel very comfortable with. While a clinician or a doctor at a gynecological exam will look for other conditions like infection or an abnormality, she will recommend that regimen of self-examination practice so that the woman herself can learn to recognize any physical changes. You teach her a certain regimen, there are a lot of regimen, she choose one regimen and stick to that. Ability to examine one's own breast and vulva is an important part of personal hygiene. Every woman, every month, must look at her vulva and see whether she doesn't have warts there or other cancerous conditions there. She, as I said, Left hand, examine the right breast. The right breast, examine the left breast. You either go like this from the side to center, you go into concentric cycles from up and down. We choose one method which you think is good for it. And I think to conscientize all women out there. Breast cancer is not a life sentence. A lot of women who survive breast cancer, and they're going to live long, cured. Look at this woman's confession.
I was first diagnosed with breast cancer when I was 21 in 2001. And then it came back again in 2006. I'm Balima Pumolo, and I'm a breast cancer survivor. Breast cancer and early detection is more like land invasion. If you leave it there for too long and it gets comfortable, you can never remove it. Early detection will save your life. I'm still here, I'm breathing, I'm living because of that. I'm going to show you how I do my breast self-examination, which I do once every month. I have a doctor here who's going to be helping me out through everything. Step number 1, check yourself out in the mirror.
And we're just here looking for any changes, any differences between our breasts from what we can physically see. Then we can lift our arms up. And here we're just doing it slowly so that we can see the range of motion and see how our breasts move. We're just looking for any orange peel skin or any denting of the skin. And we can just lean forward. And then we're just looking to see if there's any skin pulling. Lastly, make sure that we do a thorough inspection of our nipples. We're looking for any scabbing, if there's a rash around it, if there's redness, any itching. The next part of the whole self-breast examination is when we have a feel. And that's also just as important as looking. So what we're going to do is we're going to use our 3 fingers.
Yes.
And we're going to keep our hand on our hip. Okay, so it's all loose and soft in there. All the way up to your collarbone, and we're going to do soft and light.
And just feeling for any lumps.
And we're going to go around, and you can just do it in circular motions.
I feel nothing. Yay!
And then all the way up into the armpit. We're going to go around the whole boob again, and then obviously to the nipple. If you have implants, I mean, that's already an invasive procedure that you've been for. So if something's wrong with it, either way, you have to get it checked out. And then we can swap and do the other side. Start at the shoulder and come down around. Light touches and then deep, and then light and then deep. Yes.
It feels kind of funny touching yourself,
Yes.
but it's something that's
It needs
necessary,
to be
isn't
done.
it?
We need to know you.
I think the more you do it every month, the more you're going to know what's your normal and what's not your normal.
That concludes our examination. And how did you?
Like the causes I've said that the more you expose yourself to hormonal stimulation, which means early menarche, late menopause, not having a baby, exposes you to estrogens, not having a period of amenorrhea, I'm saying, because during a baby will give you a period of amenorrhea during pregnancy, will increase, is a cofactor, it's not a common. It just increases your chances, doesn't cause it. You must understand me. A cofactor doesn't cause it. It increases the chances. It doesn't cause it, because there's difference between being a cofactor and being a cause, which is a causal factor. Genetic mutation, like I said, it's in running in families. The breast cancer prevention is modification of the risk factor. Every early babies, breastfeed your babies, reduce the chances of having lack of amenorrhea, know your family history, all this, modify the risk factor and do a regular screening. Regular screening, it might be mammogram, might be breast self-examination, it might be consulting a particular healthcare provider. It increases the preventing the breast cancer. The screening is triad. There's a routine physical examination by your caregiver. Breast self-examination, which is very important. Every woman should do that. I must stress that. Every woman must do breast self-examination. Diagnostic imaging mammogram, which I said you must start it at about 35, from 35 to 50, you do it every 2 years. After 50 years, let it be done manually. The There are certain screenings that are mandatory in any woman. This is a mammogram. You must do it like the sequence I've told you before, how often you should do it. It's a pap smear that must be done from the age that you start having sex. Any woman who is sexually active. It used to say, well, the World Health Organization used to put it this way, which is, I think we must change it in South Africa. They say any woman 18 years or above who is sexually active must have an annual pap smear. I say, how? We say 18 years above. In South Africa, we have got 13 years and below who are sexually active. We exclude them. So I think now we need to have a South African system to say that any woman who is sexually active must have a pap smear, whether she's 12 or what, because human papilloma virus is a sexually transmitted virus. You can have it. We find the cancer of the cervix in very young girls because the age of sexual attacking is very small, very soon, especially after menopause. After menopause, the only risk that you can have to do a regular pap smear is that you can develop ovarian tumors. And ovarian tumors are as notorious as breast tumors. Once they develop, they start to develop by pain and abdominal distension. Is very late. Every woman should have a pelvic sauna, especially vaginal sauna, every month if she's in the menopause. And a bone scan is to assess the rate of bone deterioration, osteoporosis of the bone, so that you need HRT or not. It's a picture of a normal mammogram. No tumor visible here. Both breast examined, the nipples, no tumor, no retraction. Mammogram is commonly screened over 50. We know that menopause starts 50, 51, which means it's a routine screening after menopause. After 35 years, between 35 and 50, I said every 2 years. Women over 35, if they are suspicious lesions, you can do it more frequently. But if there are no suspicious, 2 years is enough. And there's no need for mammogram less than 35. Breast cancer is very frequent after 35. Unless if she has got a family history of breast cancer, she has got a history of having fibroadenosis. She's got those factors that increase the chance of developing breast cancer. But a normal woman without risk factor should do it as I prescribe it. And mammogram can pick up even intraductal carcinomas like this woman has got a normal breast, it looks breast, but inside there's a suspicious lesion inside the duct. Very little, which if excision is done completely, lesion will be removed completely before it metastasizes, which means before it moves to other side. Metastasis means moving to other side. I've described it as cancer CPD. Yes, pale. You've got cancer in the breast here. They tell you that the same cancer is there in the liver because it's a pitch in the liver. This is CPD. Before it's a pillar, you must remove it. And if we remove it completely excised, cured, your breast cancer survivor, you can pick up a light cancer like this one, which this one I think even self-examination can pick it up. So I don't wish when you go to mammogram, you must go and pick huge cancers like that one. If that one are not screenable because probably they are symptomatic. Every woman should go for it. We have got listening here over 50. This month is Women's Month. Mammogram. That one we will discover invasive lobular carcinoma like we have seen here, or ductal carcinoma, which are more than lobular carcinoma are very rare. Ductal carcinoma are very common. Honestly, the good Lord, God doesn't punish people. Ones that are more common, easily curable. Lobular carcinoma is rare. If diagnosed, the mortality is very high with it. That's how God makes it. God doesn't hate us. If something is common, it's treatable. It's not so dangerous. The one that's uncommon, we don't wish somebody to have an invasive lobular carcinoma. There are also special forms of carcinomas that are rare, which can be tubular carcinoma, medullary carcinoma, or mucinous carcinoma, or papillary carcinoma, in situ carcinoma. These are rare subtypes of breast cancer. The majority of breast cancer that we find is lobular carcinoma and ductal carcinoma. Lobular carcinoma is in the lobe of the breast. Ductal carcinoma is in the duct of the breast. And ductal carcinoma, I've shown you there, that mammogram that I've shown you there, that they picked it up in the duct of the breast. Is common, but it's dangerous. So mammogram is important. Ductal carcinoma, the only thing is even ultrasound or doctor's hands might not pick it up if it's very early because it's inside the duct. It doesn't show early signs like breast changes or nipple changes like you see here. So by the time, if you leave it, you not do mammogram. By the time you diagnose a ductal carcinoma, it has spread to the skin, like visible here. You must know it has already metastasized to the axillary lymph nodes, subclavicular lymph nodes, supraclavicular lymph nodes, and parasternal lymph nodes, which means it's a bit, it's metastasized. Prognosis become very poor. And unfortunately, can't tell the patient that your prognosis is very poor. It will be inhuman. We just treat in the back of our mind, you know that things are not good with her. I had when I was training, I must tell you this story. A doctor, I can't mention his name, he's late now. He was one of our lecturers who would tell a woman with a breast cancer like this one and say, Ma, go and tell your children, go and throw your wheel and everything, because we are moving away. It's inhuman to tell like that. But we wish if we look after ourselves and do breast cancer examination with physical examination, we look at the symptoms of breast, we like pain, tenderness, heat, nipple discharge, we recognize them and act accordingly. The majority of palpable masses, we can pick them up because if the mass is already palpable, about half of them already spread to regional lymph nodes. I've said that. So don't go there with a palpable mass because the chances of survival in a breast cancer is called prognosis. The prognosis is the chances of survival if you've got breast cancer. It's either poor, because poor chances of survival is a poor prognosis, or good prognosis. So prognostic factors are this one, the histological type of a cancer, whether it's poorly differentiated or not undifferentiated. The stage of the cancer of the breast is staged in a pattern, they call it TNMs, tumor, node, and metastasis. Whether this tumor, the tumor size, does it involve the nodes, has it metastasized or not? The lymph node status, whether it has involved the blood vessels or not. Majority of cancers, if they come already in a nodular pattern, survival chances, 10-year survival, the chances that you'll survive for 10 years are 55%, which means, what am I saying? I'm saying that if you've got 100 women with palpable tumors, after 10 years, 55 of them will still be alive, which means 55 will be gone. So to explain it, 55% year survival in a simple time. So we really wish mothers and doctors, we don't want to see such things in Black people. If we see such things, it's self-ignorance. Breast cancer should never come in this pattern. This person probably was delayed by alternative medicine. Alternative doctors, they tell this, they tell this, they all names these things while the cancer is growing. They tell this is witchcraft, consult appropriately while the cancer is still not at this level. At this level, there's very little one can do except to sympathize with you. It has spread to the axillary lymph node, the supraclavicular lymph node, parasternal lymph node. It's all, there's nothing, nobody can do a miracle to cure this. And the honest delay of this type of things is mentality that we have that if we got any disease, it must be a cause outside the human body, which either is witchcraft or something, any beliefs that we have. Please get educated, educate your friends there that breast cancer is there, it's treatable, and the stages, if you want in any stage, the size is small, it's not as big as this one, it's still small, it's curable. You can call yourself a breast cancer survival. But if you have got a breast cancer, it goes to the axillary lymph nodes, the supraclavicular lymph nodes, the infraclavicular lymph nodes, the parasternal lymph nodes, the chances of survival become reduced because breast cancer, even if it's in the breast here, it drains through the lymph nodes there. Lymph nodes, cancer. It's drained by the lymph towards the lymph nodes in the axilla. That's how we find the axillary lymph nodes are also involved. We'll see in the management, how do you diagnose breast tumors? If it's cystic, you can go with a needle and remove the cyst and drain it. You can do a core biopsy, or you can move a lump, lumpectomy. If you remove the whole lump, it's called excisional biopsy. You remove the whole tumor and you do a biopsy, which means the diagnosis and treatment at the same time. This can be done only to tumor if it's small. A needle aspiration can be done, but it's not very sensitive. Core needle, the needle is larger. Of course, it will give you a larger tumor, large tissue, as of being more representative or high. Wide surgical local excision lumpectomy is the most reliable and most practiced than the old true cut biopsy, which leaves some of the tumor inside. Most surgeons will do wide surgical excision. This is a needle aspiration of a cystic lesion through the breast to diagnose, see whether the breast contents are malignant or not. And if malignant, the danger of needle aspiration like this, if it's malignant, along the tract of the needle, you are spreading the cancer cells. So it's not a very popular method that must be done. You can do it somewhere there behind the mountain where you've got no other facilities to do it. If you are near the town, just go and do a biopsy. Sometimes there's a true cut biopsy that the companies make a needle like a gun, it shoots inside the tumor and give you the biopsy. The danger is saying that if it's benign, you're lucky. If it's malignant, you must know along the path of the needle, you are spreading the cancer cells. So that's something that should be advocated. This can be done. I mentioned it just for academic purpose that it can be done, but it's got its own dangers. Of course, any diagnosis test has got its own benefits and side effects. But the standard is wide tumor, wide excision of the tumor with wide margin of the tissue, which is called excisional biopsy or lumpectomy. Lumpectomy is removal of the lump, which is a treatment and a diagnosis. So if you go with a tumor of the breast and the doctor says, no, we must go and do a wide margin of normal breast tissue exercise, we must go to theater and remove it and see what it is. After removing, if the pathologist says removed, you must know you are cured. So it was diagnosis and treatment at the same time. Like this one, she's got a tumor here. We removed with normal margins, wide tumor excision. And the pathologist says there's a tumor-free area around here. We know that we have removed the whole tumor. If lymph nodes are negative, we become happy. So ultrasound has got its value in diagnosing, in distinguishing between solid and cystic tumor, and to monitor the growth of each tumor, being a fibroadenoma or anything. And if you have to do a needle biopsy, like I told you about needle biopsy, it can guide you. So if you do ultrasound, you can find things like this. This is a cyst on ultrasound. One feature that a woman should observe, I don't wish anybody should have that. What you see here is, I say, pod orange. It's an orange. If you take a picture of an orange peel, it looks like this. And characteristic feature of cancer of the breast is called pod orange. Pod orange is from an orange peel. If you find a breast looks like an orange peel like this, it's late. It's late. It's already metastasized and it's gone to the, it's gone under the skin and blocks the lymphatics under the skin, which means it's a white breast. The whole breast, there's no breast, it's all cancer. You don't wish anybody should come to you with pod orange. You see the tumor, it looks like an orange peel. If you look at that orange peel and look at this tumor, they're the same. That sign is called pod orange. You don't wish to find somebody at that level because of the terminal sign. The breast must come like this, although if they've got tumor, they mustn't have skin involvement. If they've got skin involvement, you must know that the tumor is spread to the side and the By that time, it's Port Orange would be secreting maybe even ulcers or sinuses over there. That's very late. We don't wish to find it like that. If you find it like that, you're not doing very well, because even in that case, the treatment will only be radiotherapy, which is palliative. Palliative treatments means we just treat you so that you mustn't spend the last few months of your life in pain, like they give you radiation like this. There's no place for surgery in tumor like that one. We need to have a tumor in this is MRI investigation of a tumor, which is done very rarely because mammogram is very good at diagnosing that. You don't have to go to a deep, very expensive MRI tumor, but this is an MRI picture of a patient with intraductal carcinoma or a patient with a tumor which is there. MRI won't tell you whether it's carcinoma or not. It does tell you that it's a tumor. Only biopsy that will tell you whether it's cancerous or not. Medical management of chemotherapy is always neoadjuvant, which means after surgery, if you think you've left some minor microscopic tumors there, you can give chemotherapy. Most cancers respond well to chemotherapy. They will give anti-neoplastic agents, which anti-cancer drugs, which will kill microscopic cancer that might be left there after surgery. It might be neoadjuvant. Neoadjuvant means you give it before surgery and then you go to surgery. The aim why you give it before surgery, you want to shrink the tumor, the size of the tumor, so that at operation it can be operable if it's too big. But adjuvant is after surgery. Very rarely you have to neoadjuvant, because by the time you give neoadjuvant, the tumor is also growing. We don't wish to give neoadjuvant. We must go for, we wish you must get a tumor early and maybe supplement with anti-neoplastic agent after surgery, which is neoadjuvant. The tumor that has metastasized, there's no need for surgery, I told you. Because if it has metastasized, surgery doesn't help. It is all over. Only chemotherapy, which is very notoriously valuable, because if you got a tumor in the breast, it metastasizes to everywhere. It goes to the liver, it goes to the intestines, it goes to the kidneys, it goes to the lungs, it goes to the brains. You can't give the whole body metastasis or chemotherapy. That chemotherapy will just slow rate of growth of the tumor cells there, but it won't stop the rate of growth. And as if its rate of growth slowed, the life will be prolonged. Now the question that the 5 year survival will be more, they can prolong your life. Now the question is, what quality of life? Because in medicine we have to distinguish between prolongation of life and prolongation of suffering. Because that's life full of pain of cancer, but it's prolonged, right? So you must take a decision. So it's a very ethical decision that you must take if a patient has got a metastatic breast cancer like that, whether you should start a chemotherapy or not. We just let the cancer do its job, because if you start on chemotherapy, you are doing prolongation of life. But ethics might compel you to start treatment. It's a given. Breast cancer are sensitive to estrogen. Hormonal therapies, when medication that blocks certain hormone, like anti-cancer drug or anti-estrogen drugs also, these are some of the palliative drugs. Treatments of cancer are classified surgically into radical mastectomy. Radical mastectomy is one of the first treatment of cancer that was done before, when cancer of the breast, when it was still diagnosed very early, before mammogram was done, self-breast examination was not there, ultrasound training was not worldwide. They used to do radical, and it was really radical. It's not done now. Don't do that radical. They're removing the breast and their whole breast, and the underlying chest muscles, and leave the ribs, including the pectoral muscle margin. The lymph node in the axilla, they go into the armpit and remove everything in breast cancer. It used to be called toilet mastectomy. They remove everything. It's a radical thing. It's not done now. No surgeon does that these days. If you do radical, you remove the lymph node in the axilla, in the armpit, and remove the entire breast and all breast, and the woman remains like this. There's a benefit and side effect, and why the radical mastectomy was left. If you remove the lymph nodes, the draining lymph nodes here, there's nothing to drain the lymph of the arm. So a patient present with a swollen arm because the lymph now is blocked here. There are no lymph nodes there. So that's why now they do modified radical mastectomy. They leave some of the lymph nodes inside here. Whether involved or not involved, they leave them so that the arm cannot be. Well, this arm can be so swollen that it's called elephantiasis, can be very big. Now they do radical mastectomy, modified radical. They modify it. The radical and modified radical mastectomy include removing the entire breast. The breast, you remove it, all of it. During modified radical mastectomy, surgeon remove some underarm lymph nodes. You will sample the lymph nodes, don't remove them all to avoid that lymph accumulation and arm swelling. They radically remove the entire, all the lymph nodes in here. But in modified, you leave others so that you mustn't have this problem of swollen arms. So what's done these days? Modified radical mastectomy. Remove some, and leave some of the lymph nodes so that lymph can still be drained. And if that way, then the woman is become, but doesn't have all hands are equal, but it's cosmetically and medically better. If the tumor is one side, it's localized on one place, the type of surgery they will do will be partial mastectomy. Partial mastectomy means part of the breast will be removed, or you can call it local excision. We just remove the tumor where it is and leave the other normal tissue. Don't remove the entire breast. If the tumor is somewhere here, we will mark where the tumor is and make an incision and remove the tumor with all deep-seated organs and suture it. That's segmental mastectomy or partial mastectomy. And you can have a biopsy like this, which will tell you that the margins are tumor-free. If the margins are tumor-free, you say, hurrah. If they say the margins are not tumor-free, you either go again and do partial mastectomy, or you do chemotherapy, depending on the type of histology that you have. Radiotherapy, there's also a place for radiotherapy. And usually, radiotherapy is for tumors that are inoperable. As I said, it's a palliative measure, just so that the woman must not spend the rest of her life suffering. They can use teletherapy, which they use an external beam like an X-ray, or it can be a brachytherapy where they put radioactive needles inside the breast tumor itself, and those radioactive needles that bend the tumor inside. It's always additional radiotherapy after surgery, the same as chemotherapy. It's additional, it's adjuvant. Lumpectomy or mastectomy reduces the chance of recurrence. After lumpectomy, you do radiotherapy or chemotherapy. The majority of tumors that are found early, you do what you call palliative radiotherapy. Palliative radiotherapy, or if they are found late, if it's late and it's inoperable, you do palliative radiotherapy. Palliative radiotherapy, the aim is to shrink the cancer cell or to slow down its growth and control symptoms. It doesn't cure. I've asked that question before that. You shrink the tumor or you slow down its growth, you prolong life. What kind of life is prolonged? Is it a good life or a bad life? Hence, you has to take an ethical decision with the patient. You are prolonging your life, suffering life. You want this life prolonged or not? Because there's a difference between prolongation of life and prolongation of suffering. It's not all life that is there. The picture of a machine at radiation therapy, it will come, radiation X-ray will come from here, come and radiate the chest. And as it radiates the chest, it's not specific to the chest wall. It also radiates other tumors, other, you can say, the lungs and other things. This is teletherapy. Inside the breast tissue, they implant the needles here. These needles are radioactive. Over some time, a week or two, they stay there. burn the tumor cells. After that, they remove them. The management after mastectomy, if you have removed the breast, you can put the silicone implants. The plastic surgeon will put silicone implants. Or you can buy a padded bras here. There are bras that are padded. One will never see that the another breast is not there. Or you can do mastoplasty. This is a padded bra. You buy this bra, even if you have removed all your breasts, you still look like a woman. But if it's one breast that's removed inside the bra, there are a lot of pads that you can prove inside there, different sizes. You buy the size of the other breast, and people will not see that this woman has got one breast. So it will just look the same. So I think women, let's do regular breast screening, the cancer. Let's know our family history and avoid necessary radiation, unless you're working in radiation. The message of this month in conclusion is that women must love themselves. Women, they always say, men don't love us. Why should we love you if you don't love yourself? Love yourself first, then expect others to love you. And if you love yourself, you do breast self-examination. A man won't do breast examination. He will do caress you and press the breast, foreplay, but it's not breast examination. The only love that you can give yourself is to do breast self-examination. You take care of yourself. Take initiative of your well-being. And expect others to love you. Love for others is secondary love. The primary love is yours. Love for others is secondary love. The primary love comes from you. So I think we don't know. Many men ask women, they don't know how to love women. Women must show that how we must love them. Men must love them. Because how should you love? I cry every time when I see a woman coming with advanced breast cancer. You don't love yourself. How should we love you if you don't love yourself, women? Really, let's love Ladies and gentlemen, thank you very much for listening to me. I must say we are lucky. There are different methods. Science has advanced so much that breast cancer can be detected and is curable. It's not a killer disease as before. What we can pray is that science must keep on continuing to improve, and treatment methods must also improve. But we must also thank God for making this possible for us, that we live in the era where cancers are treatable, both breast cancer. That's why I saw some women, they were really thanking God that they live in the era where breast cancer is treatable. Thank you. You can open for question. Let me go and unmute and make you yourself. I want to go somewhere where I can make you unmute yourself. Let me go to security. Okay, you can unmute yourself. You are allowed to unmute yourself. Let me see. Participants. Am I audible? Somebody can unmute himself.
Yes, you are audible.
I think you can unmute yourself. Somebody say something so that I can hear whether I can hear you this side.
I have a question.
I can't hear the participant. Can you, Ramroga, say something?
Yeah, I can
say
hear
something.
you.
I want somebody with a video, but I can't hear you this side either. But I have permitted that you must unmute yourself. Let me see, do like this. No, they can unmute themselves.
I have a
Okay,
question.
thank you, ladies and
Dr.
gentlemen. If
Mahapa.
there's no questions, let's close the session. But I think there must be something wrong because I can't hear you at all.
Yes, Dr.
Hello?
Mahapa.
Hello?
Can you hear us?
Somebody has got a question?
What did I do?
I can hear you, Dr.
No,
Mahapa,
but
but
on my
we
side, I
cannot
didn't
hear.
stop you from unmuting yourself.
Can you hear the person asking the question?
Yeah, my question is, is it compulsory or should a person go for pap smear?
Okay, ladies and gentlemen,
after
with that,
50 years?
it's a problem. Let's close the meeting. I think the meeting
Dr. Mahapa,
is
Dr. Mahapa,
it's closed because
Dr.
I really
Mahapa.
cannot hear what you're saying. And or somebody raise his hand.
Dr. Mahapa.
No, there's nobody raising the hand here.
Then. Hello?
Present. Please try again later. The subscriber you have dialed is not available at present.
Anybody's raising the hand?
Is not available at present. Please try again later. The subscriber you have dialed is not available at present. Please try again later.
Okay, thank you very much.
Doctor.
Okay, these ones have got Soli.
Doctor.
Socks.
Hello?
Raise your hand. Okay,
Hello?
Chipape, you've got your hand. Can
you
hear me?
Somebody wanted to ask a question earlier.
You have muted. I'm asking you to unmute.
No,
unmute yourself.
I'm not. I've unmuted, Mara. You don't seem to hear.
It might be network problem.
You're not muted. Okay, let's hear.
Yeah, my question is.
I can hear you.
Can you hear me? Hello? Dan, can you hear me?
Doctor.
Don't worry, I think I'll do like this.
Can you hear me, Dr. Mahapa? Something wrong on, I think it's something wrong on Dr. Mahapa's side.
Yeah, because
and I'm sure on some very, very important questions. Which
my question was, if a person is not sexually active, compulsory for that person to go for pap smear if that person is 50 years and above. So because he was saying in his presentation that after 50 years, there should be an annual pap smear. Thank you.
Now, Enterprise, I'll answer. I've got a phone here. Let me answer. I didn't say, when I mentioned compulsory smearing, pap smear, I said, we have got a problem in South Africa. The World Health Organization says 18 years or above when you are sexually active. I even said in South Africa we'll change it because we studied early because the sexual device age. What must be done yearly is mammogram, breast cancer screening after 50 years must be yearly. 35 to 50, if we are not living high risk, yearly, depending on the risk profile, the total look at the risk profile. If you've got a family history of cancer, history of fibrosis, the doctor might say more frequently. And I said, less than 35 years, very rarely to get cancer. So it's not necessary, it's not mandatory to have a mammogram. That's what I've said. Is it clear now?
No, the question was about the pap smear, not the breast.
Yes, I was correcting that.
Not about mammogram.
Yes, I was correcting that notion that I said smear yearly after 50 years. I said pap smear from the time you start sexual intercourse. Forever.
Okay, thanks.
Thank you. Can hear them. Another one. I see one hand up. Papa's hand is up. It is not talking. When I look at
Doctor, I wanted to indicate that people are talking. We hear them, but we are not hearing them. I just wanted to alert you that people are asking questions and we could hear them, but it seems as if you were not hearing them. I just wanted to say that.
You couldn't hear me because I got that's why I'm talking with the cell phone here. Because on the computer, something is not good.
No, fine, doctor. I will lower my hand.
Sure. Ajajima, you have got your hand up. So everybody's hands is down. I think if everybody's hands is down, Marani. Let's hear Rami.
Good evening, Doctor. No, for me, it's just to take this opportunity to thank you so much for offering this session free of charge, taking your time instead of being with your family, but decided to come and give us such an informative session. Really, thank you so much, and we're looking forward for more to come. Thank you so much.
Thank you very much, Ravi. I appreciate that. Shangwi is my relative. Shangwi Mahapa.
I'm the daughter-in-law, doctor. Thank you for the opportunity.
Who married you?
Yes, I just wanted to
my
find
brother's
out.
son.
Yes.
Okay.
Yes. So my question is, based on my experience, most of the breast cancer patients, they don't get to have a variety of choice when it comes to treatment. We get exposed to only one channel of treatment, which is mastectomy.
I said best if I was to treat a breast cancer patient, to go for surgery. The reason why they go for mastectomy is because all modified medical mastectomy, of course. Because with mastectomy, you are sure you have removed all the tumors. If you do segmental mastectomy or lumpectomy, chances are that you might have to go back again because you might not remove all tumors. Because when you operate, you don't see where the tumor ends. That's why most surgeons, they say, okay, silicone implants are very good now. Braided bras, cosmesis is not a problem. Mastectomy. That's why they say so. So that's the safest.
Yes, doctor. And even after the mastectomy, there needs to be more education on the treatment that you get exposed to, because breast cancer nowadays is about the diagnosis and the treatment, but from the year after surgery, after radiation, you don't get more information. Now it's like you're stumbling over rocks and everything as you go, and you get exposed to the treatment that you didn't even have knowledge of, only to find that because you took mastectomy or you took lumpectomy, this is the road that you're gonna walk, but already you cannot even go back. So I'm pleading that in the future, when we talk about this breast cancer treatment and diagnosis, can we also speak further than that as to what furtherly after 2 years
Follow
of
up
that treatment, what can you go through? Thank you.
Yeah, I think that's a good thing, but I have made it deliberately beyond the scope of this practice, because that is scope of oncologists. There are various ways oncologist treatment is improving every time. If I'm going to step in that territory, I'll have a knowledge deficiency or what's happening oncologically thereafter. But maybe next time when I do like this, I'll invite one of the oncologists to come and tell that part, because that's his field. It's slightly beyond my field. Thank you, but I appreciate that. Zoli, Ndanti, Socks. Socks has got his hand up. Same as Majaji. You know, Zoli
Yeah, Dr.
is a medical doctor.
Can you hear me now?
We attended from one together at Mutlagane.
Can you hear me now?
is a medical doctor. Me and him, we attended from one doctor from 3 together at Mutlagane. They are raising hands, they are not talking.
Yeah. Can you hear me? Can you hear me?
Yeah.
Am I audible?
Yeah. Yes, sir.
Yes, sir.
Thanks, Ntate Mahapa. It's true that Dr. Mahapa were in Mutlagane together in
1974.
I think it's 74. Yeah. We started from one there together until we all ended up in Teflo, then to Medunsa. What I wanted to ask is, what about the diet as far as breast cancer is concerned? I mean, normally with all disease, they will say diet, exercise, non-smoker, and the limitation of alcohol. My concern is that the type of food we eat from where the source is not good at all already.
Yes.
I mean, a chicken is an adult within 37 days. Then they slaughter it, you must eat it. That chicken cannot even run a kilometers, you know. And then the other problem is the sugar content of most of the foods we are eating, even from the source. And then, of course, hormonal treatment. Will they be having some contribution in this breast cancer issue, Dr. Mahapa? Thank you.
Yes, actually, what you have said, Dr. Mdlanzi, you have contributed. Just fat, sugar, and high fat and sugar, reduction of obesity is modification of risk factor. What Dr. Mdlanzi is telling us that we mustn't eat high fat diet, because high fat diet will increase your sugar diet. And you know why in menopause, when you've got obesity in menopause, you've got a chance of developing cancer. The source of estrogen in menopause is peripheral conversion of fat into estrogen. So we want a woman in menopause to be hypoestrogenic. So it's not good to have a fat diet because it will give you obesity. As Dr. Mzanto say, high sugar diet is not good. It increases the chances of menopause. Of course, contribution. Right, you must look at your diet. Consult your dietitian, and eat normally. My judge is listening. Mr. Chipape?
Yeah, Doctor, I wanted to appreciate what you are doing because I'm a life science teacher. I need to know almost everything about, health issues because I sometimes give talk to women. So I must be able to encourage them to do the right thing. So I need to have information. Don't be surprised if I get into your link. And I also share your link with, in the groups that I belong, because there are women there, and you are doing a very great job free of charge. May the good Lord continue to bless you as you educate people free of charge. So we want to really appreciate what you are doing. Thanks very much. And there is someone was saying, can the recording be shared so that those who missed might benefit?
This one I'll share. I'll tell people where I could share because there's no, the previous one I couldn't share because it had pornography. This one I'll share. I'll put it on a YouTube. And I'll give the people where the YouTube channel is. I think I'm going to share it as a breast cancer webinar by Dr. D.T. Mahapa. You just go to YouTube and say breast cancer webinar, D.T. Mahapa. You get it. Thank you, ladies and gentlemen. The questions won't stop. I appreciate your attendance very much. I don't know what the next topic will be like. People ask me to repeat pelvic organ prolapse. I'm not going to repeat it now because I think it's somewhere in November. But probably there will be another topic next month, which I don't know what it is. But I'll something for next. Thank you very much. Thank you very much.
Thank you. God bless and good night.
Thank you very much.
Thank you, Dr. Mahapa. Thank you, Dr. Mahapa. Good night.
Thank you.